Thank you for inviting us. Good afternoon. Today's case starts with a 56-year-old male from the Philippines who came to the ophthalmology outpatient department with a chief complaint of blurring of vision of both eyes. 14 years prior to consult, the patient had gradually progressive blurring of vision of both eyes, both at near and at distance, with noted difficulty seeing particularly in the dark. No consults were done at the time, and neither were there any medications taken. No other symptoms were noted during this period until eventually the patient's vision had deteriorated to such an extent that 2 years prior to consult, the remaining visual acuity was allegedly just light perception in both eyes. Persistence of symptoms prompted consult to our clinic. The patient's ocular history and past medical history are non-contributory. During the interview, it was elicited that a male sibling of the patient has a similar problem, having both blurring of vision and night blindness of both eyes. The patient's personal and social history are as follows. Upon assessing the patient, he was assessed to have bilaterally dense, intumescent, white cataracts causing secondary glaucoma, requiring emergent surgery. Incidentally, there were peculiar findings on the ocular exam with regard to the patient. There was a low-grade anterior chamber inflammation of 1+ cells. The right eye also exhibited iris atrophy. At the time, diffuse fine stellate keratic precipitates were also noted on the corneal endothelium of both eyes. Gonioscopy showed 180-degree angle closure without any peripheral anterior synechiae. No bridging vessels were seen on the anterior segment and on the trabecular meshwork of both eyes. Predictably, the intraocular pressure was elevated on both eyes, with the right eye having an IOP of 28 and the left eye having 30. The case was treated as an emergency, with phacoemulsification being done, with the right cataract being removed first and the left eye being operated on soon after. Minimal improvement to the visual acuity was observed, and the vision improved from light perception to hand motions bilaterally. With the removal of the lens opacities, a clear view of the fundus was now possible. Here now are the bilateral fundus photos of both eyes, now seen through clear media. Aside from the disc notching, bayoneting, and enlarged cup disc ratio, other notable findings are the diffuse pigmentary deposits in the retina, vessel narrowing, and slight pallor of both optic nerves. Due to the history, we decided to examine the patient's brother, who also had similar symptoms and found identical retinal findings as the patient. In summary, this is a case of a 56-year-old male with progressive blurring of vision of both eyes since childhood, which was initially assessed to have secondary glaucoma at the clinic. Incidental findings, both pre-operatively and post-operatively, show that this patient's case might not be as simple as initially thought. Based off the other clinical findings on the anterior segment, what is the most likely diagnosis? Fuchs heterochromic iridocyclitis is a rare, albeit relatively benign, form of anterior uveitis, with a total prevalence of around 1 to 8 per 100,000 people. Moreover, a local Philippine study shows that Fuchs heterochromic iridocyclitis is responsible for 3% of all uveitis cases, according to data from a large high-volume tertiary hospital. The findings of iris atrophy unilaterally, in addition to diffuse stellate keratic precipitates and a low-grade anterior chamber inflammation bilaterally, led to the clinical diagnosis of Fuchs heterochromic iridocyclitis. This diagnosis was maintained not only because of the classic clinical findings, but because further systemic workup exhausted possibilities of other forms of anterior uveitis. Moreover, throughout the patient's course, while the keratic precipitates were present on and off, the low-grade anterior chamber inflammation was sustained and wholly unresponsive to steroid therapy, which is a hallmark of the disease. To further substantiate the diagnosis, I decided to look into the literature with regard to the clinical picture of Fuchs. In the literature, almost all patients with Fuchs heterochromic iridocyclitis presented with diffuse fine or stellate keratic precipitates on initial presentation. Cells in the anterior chamber is also a common finding among those diagnosed with Fuchs, and like what was found in the patient, is unresponsive to steroids. What can be noted is that despite its name, heterochromia does not necessarily present in all cases, and that oftentimes the iris atrophy is a more common finding. The fundus photo shows classic findings for what disease? Retinitis pigmentosa is a group of disorders that lead to progressive atrophy of the rod photoreceptor cells, leading to secondary death of the cones in the latter stages of the disease. It has a total prevalence of 1 per 7,000 and is classified as a rare disease. Current treatment for certain types of retinitis pigmentosa is focused on delaying the progression of the disease through high-dose vitamin A supplementation. But aside from that, no other current treatment exists for this degenerative disease. The diagnosis for retinitis pigmentosa is fairly straightforward, with typical fundus findings including pigmentary retinal changes, termed bone spicule formation, attenuation of blood vessels, and optic disc pallor. The mechanism of the bone spicule formation is such that after an area of the retina where there is degeneration of photoreceptors, there is migration of the inner retinal vessels from the outer plexiform layer towards the retinal pigment epithelium. This triggers the RPE cells to migrate along these vessels towards the inner retina. The bone spicule formation now seen is a manifestation of the RPE pigments along these vessels. Attenuated blood vessels is a direct result of the reduced retinal vascular demand owing to the diffuse photoreceptor cell loss. More objective tests, like an electroretinogram, would typically show extinguished responses, and finally, genetic testing would definitively identify if a patient has the disease. The inheritance pattern of RP is variable, with sporadic autosomal dominant, autosomal recessive, and X-linked being represented in the literature, the importance of which comes when a patient would like to know whether their offspring might be affected by their disease, and so they might be advised accordingly. Only 2 cases were reported in the literature of patients having bilateral Fuchs heterochromic iridocyclitis and retinitis pigmentosa together. While no causal link can be determined between these 2 disease processes, further research can perhaps determine if there is an underlying causal mechanism or if this is indeed just a product of chance. Going back to the patient, the slide shows a simplified genogram showing that only the index patient and his brother are affected by retinitis pigmentosa, and that he is the only one among his whole family with Fuchs heterochromic iridocyclitis. Finally, this patient still had lingering issues related to his disease that still needed addressing. Our goal for this patient was to regain functionality in his activities of daily living, and to this end, he was referred to rehab for low vision training. Finally, and often overlooked, his disease has a genetic component, making reassurance and further genetic counseling a necessity, not just for him, but for everyone in his family who might exhibit similar symptoms. Excluding the diagnoses we already know, the final assessment for this patient is Fuchs heterochromic iridocyclitis both eyes and retinitis pigmentosa of both eyes. Here are my sources, and thank you for listening.